And we will have a total of 10 presentations, each with challenging cases in the field of ocular oncology. So we'd like to get started, and we would like to call Dr. Jaren Saktanasadi, who's from Thailand. He will be our first speaker.
Chairman, Dr. Shields, Professor, and friends. Today, my name is Dr. Jaren Saktanasadi. I'm working at BNH Hospital, and I'm also the consultant at Children's Hospital of Thailand. Today, I present the case of 6-year-old boy presented with leukocoria. He was referred from elsewhere, like 5 or 6 hours from Bangkok. So the local ophthalmologist thought that he could have the retinoblastoma. So he referred for second opinions. So when they saw a child with leukocoria like this, the list of differential diagnosis comes up, including the serious condition like retinoblastoma and the vision treatment like Coats disease. Let's take a little bit look closer. This is the right eye of the patient. He has no light perception in his right eye, and the pressure is rising to 35 millimeters mercury. The cornea is clear, anterior chambers, no cortisol deposits, no pseudohypopyon, and the iris has an NV. The lens is clear and looks stable. This is the fundus of when we do the examination under anesthesia. You can see that he has the retinal detachment of 4 quadrants with the exudates under subretinal. Okay, which at the temporal, we can see the abnormal vessel with some hemorrhage. The left eye was perfect. So we took him to do the first slit angiogram, and we found that he has a telangiectatic vessel with early and late leakage. Sorry that we don't have the ultrasound because the machine was broken at the time. CT scan shows that the soft tissue size about 2 millimeters and no intraocular calcification, and the brain was normal. So now we have 6-year-old boy with unilateral leukocoria and a massive exudative RD, neovascular glaucoma. So, what do you think that is the diagnosis? Anyone think that this is a Coats disease?
I think Coats disease would be high on the list. You also want to make sure this is not FEVR, and there is an exudative detachment that can occur with morning glory disc too.
Thank you, Mr. Carroll. Retinoblastoma is always in my differential diagnosis because it's the most common intraocular malignancy. Everyone knows that, okay? But from the clinical, I'll pick Coats disease. So I talked to the mom that he has Coats disease, and we have to make sure that the mom understands all the situation and not to lose follow-up, because the Thai parents are always like, oh, this is not a cancer, so I'll stop, come and follow up, and we will lose the patient. So I'll talk to the parents to come back in another 1 month. 1 month after the eyes become more swelling, he has a ciliary injection like that. The cornea become hazy. The pressure is rising to the 43. Even we give him 2 anti-glaucoma eye drops. And what made me serious is about the lens that he has the lens subluxation here. So what I thought is about something pushing the lens or something invading the ciliary body. This is the second EUA. and still have the total exudative renal detachment with a clump of pigment at the posterior pole, more hemorrhage from the first time. And we have the lens of luxation here. Do you think that it is still be a cord disease with this more aggressive behavior? Or you think that or you want to shift to retinoblastoma? Or could be something else like meduloepitelioma, which is less common. So I think that if cord disease, what will I do next? So probably I will do the conservative treatment to lower the pressure, or I do the enucleation if the child is very painful, because no visual prognosis in this case. If the retinoblastoma is sure that it's group E, and we need to do the enucleation in this case. So after discussion with the parents, they understand that there are clinical features that overlap between cord disease and retinoblastoma, because 10% of retinoblastoma can absent the intraocular calcification. 20% of the cord disease can have the intraocular calcification. Telangiectatic vessels we can see in both cases. So we discussed about this and we removed the eye because we need to know the pathology, and this is a very painful blinder. The pathology came back with the diagnosis of cord disease. So Dr. Jerry used to give a talk about how to distinguish between cord disease and retinoblastoma. This is very easy to remember from the front of the eye, from the reflex to the back of the eye to macula. If the patient has the yellow reflex or the white reflex, this is something cholesterol present in the anterior chambers, or is a pseudo-hypopyon. Is it the vitreous is clear, or the patient has vitreous seeds? The color of the subretinal fluid is also important. Yellow in cord disease or white in the retinoblastoma. The caliber of the retinal vessels, like triangular, is it sausage-like in the cord disease, or like more just enlarged in the retinoblastoma, or the macular appearance just accumulate the exudative or have a mass in the macula. This is the case that they reported from China. These 3 retinoblastoma patients were misdiagnosed as cord disease and endophthalmitis, and all the patients underwent the surgery, and the pathology came back with retinoblastoma. All 3 patients had brain mets, and they all died. So it's sad. We don't want that to happen. So just think about the worst that it could be, and you will not miss it. This case, we didn't miss it. We make a diagnosis of group E retinoblastoma, but the parents just took the babies away from the back, and we cannot contact the patients. 6 months later, the parents took the babies back to the hospital, and the babies keep crying with corneal ulcer, and their eye is like rupture and explode. The vitreous is just on my floor. This is very, very sad. We don't want this to happen. So thank you, Dr. Lojanapon, for inviting me to talk to the meeting, to a wonderful meeting today. Dr. Serene for helping me preparing the case. And also thank you, Dr. Jerry and Carol Shields and Dr. Laongsi for all the opportunities and teach me a lot in oncology. Thank you very much.
Thank you, Dr. Jiren. One thing I've learned over the years is Don't be afraid to perform an enucleation when the diagnosis is unclear. And you did the right thing in your case. The child had high pressure, was going to have pain for life, and you removed the eye. I just caution people, and Dr. Eagle, our pathologist, will support me. Evisceration plays no role in an ocular oncology practice. We never eviscerate, no matter what. And even if a patient comes in to our practice for a blind, painful eye, we will treat them with enucleation, but never evisceration. Just like you indicated those 3 cases that proved to be retinoblastoma, we've seen eyes that have had evisceration that proved to have melanoma and medulloepithelioma. You just don't know, so it's always safest to enucleate the eye.
Thank you, Dr.
Thank
Carroll.
you.
So next speaker is